afternoon, everyone. Welcome back. We've been away took a little hiatus as the hospital continues to recover from our COVID surge. I'm Dr. Cacciabaudo. I'm the medical director here at Peconic Bay Medical Center. With me today, I have Dr. Stanley Katz. He is the chairman of Cardiology, the director of the Cardiac Catheterization Lab, and is the reason why I'm part of Northwell Health. From a long time ago, he recruited me out of the city. Just going to acknowledge we are wearing our masks. We are more than 6 feet apart, so we can take our masks off, and so I think everyone can better engage with us. So thank you for your time. So Dr. Katz, prior to joining Peconic Bay Medical Center 4 years ago, was the senior vice president and chairman of cardiology for the Northwell system. He was the founding father of interventional cardiology here on Long Island. I think you were the first to do percutaneous?
Not the first to do stents.
Do stents in the New York area, right?
And I think Jeff Moses and I were the first two.
So Dr. Moses was a cardiologist at that time at Lenox Hill, currently at Columbia, I believe. The way we approach heart attack care on Long Island was really defined by the vision of Dr. Katz.
So there I was definitely the first in New York State.
There you go. So we at Peconic here on the East End are so lucky to have a visionary such as Dr. Katz taking care of this community, transforming cardiac care here at Peconic Bay. I believe we remain the #3 STEMI center here in Suffolk County, behind Southside Hospital in Bayshore and Stony Brook University Hospital. So we are, and we're only coming up on our 3rd year of being in the business of performing interventions on heart attacks. So it's been great. Although we don't have many visitors to the hospital, during the COVID surge, we did open up our new cardiac cath lab, which are 2 exquisite labs that Dr. Katz left his mark on, with mega screens and a lot of space to do procedures in, as well as a space that's yet to be defined for future use. I think we can talk about some ideas of what can go into that space while we're here. It is a beautiful, beautiful space, part of our Corey Critical Care Pavilion. It's up on the 3rd floor. It is a place of innovation. It is a place of healing. And every patient that is cared for there has nothing but accolades on the beauty of the place and the care that they receive. So thank you for bringing all of that to us here on the East End. So for those that don't really understand what an intervention on a heart attack is, maybe you could just walk us through.
Sure. So I did my cardiology training in the 70s, and when you came in with a heart attack, the big discussion was whether to give you oxygen or not, and whether to give lidocaine prophylactically. And you were literally in the hospital for 3 weeks. Resting at bed rest. And you had your permanent damage, and that was it. In the 80s, it came to, there was a landmark paper in the New England Journal in 1980 from Washington, the state of Washington. There was a cardiologist by the name of Marcus DeWood who was in Spokane, Washington, and organized a study where the 3 hospitals in Spokane, the patients that came with a heart attack were taken to the cath lab, had an angiogram, and then went for bypass surgery. His theory was that doing a bypass operation in the midst of a heart attack, you would do better than if you did nothing. And then he published his findings in the cath lab, several hundred patients, and showed that all of them, not all, about 85% of them had a blood clot in the artery that was causing the heart attack. And that's what changed our whole thinking about what causes a heart attack. That it was formation of a blood clot occluding the artery and therefore causing permanent damage to the heart muscle. As a result, a German cardiologist, what was his name?
Stenziger? No.
Something like that. So he took an old drug, streptokinase, and took these heart attack patients to the cath lab and injected the streptokinase into the artery to dissolve the blood clot. And he did this in Germany and then came to Mount Sinai in New York, where he was doing it. I, at the time, was running the cath lab at Winthrop. This was 1982 or 83, and I started doing intracoronary streptokinase to try and dissolve the blood clot. And then at the same time, angioplasty was starting, and I went to Atlanta to a course run by Andreas Grinzik, who invented angioplasty. Came back to Winthrop and started doing angioplasty, and went to another conference at Stanford, where for the first time I saw this cardiologist doing angioplasty, Jeff Hartzler, who in my mind to this day was the best technician that I'd ever seen do procedures in the coroners. And he, within 3 months of me seeing him working, he published a paper on the first 5 acute MI patients that he did angioplasty on. And so I thought, this sounds like a much better procedure than injecting the streptokinase. So this was 1984 at Winthrop. I started doing angioplasty on acute MI patients. And the first 3 patients I did, I got the artery open, but literally within half an hour the artery closed again. And so I sent the angiograms to Jeff Hartzler to review, and he, within a week, I got a letter from him. This was before emails.
He's dating us.
Saying that you're doing a good job, you're doing the right thing, try giving more heparin, try give verapamil, intracoronary, and so on. So I continued doing it, and it started working out great.
Just one thing, I just got a comment, if we can speak a little louder so that they can hear.
Where did aspirin fit into what?
So aspirin, even at that time, was not part of the regime that you gave. You brought the patient to the cath lab, you put a wire in a balloon, and you opened the artery. So I was doing that at Winthrop, and then in 1991 I went to North Shore, and they had never done that. They were a TIMI site, so for the last 3 years they were using thrombolytics for acute MIs. I was there literally a week when one Friday night one of the trustees came in with a heart attack, and I really wanted to take him to the cath lab, but we weren't set up. We hadn't done it before. We didn't set up a team, and so on. And so we ended up giving him not streptokinase, TPA in the ER, and he refused, believe it or not. I think it's because he came in very early. But a month later, I organized an on-call team, and then at 10 o'clock one morning, a young guy came in with a heart attack, and we took him to the cath lab, and we did angioplasty.
History was made for North Shore University Hospital. Following
Winthrop.
No, but it was still the same trailblazer.
So I started going to watch the Washington Hospital cardiologist.
Yep.
to their first TCT meeting, which was about 1993 in Washington. And Marty Leon, and I saw him using biliary stents in bypass grafts. And I came back to North Shore, and Susan was running things, and I said, we're going to start doing biliary stents here. So she said, well, we've got to write up a protocol. I said, no, I have a patient tomorrow, because it's in bypass grafts.
Okay, because
I have a patient tomorrow. I want to do biliary stents on this patient.
Can I just comment? I just want to comment to what this means. So biliary, the bile duct, which is a stent that you would put in for your gallbladder, is big. Most coronary arteries are small, and so a biliary stent would never fit in the artery that supplies the heart muscle. But a bypass graft is a vein, typically coming from your leg, that would accommodate the size of a biliary stent. So
Susan went to administration. They called the FDA, and the FDA said that it's legal. It's an approved device for a non-approved indication.
Okay.
And as long as you explain that to the patient and the patient's agreeable, you're allowed to do it. So I started doing biliary stents in 1993 on bypass grafts at North Shore. And then a year later, the FDA approved the coronary stent. But the way they approved it was that you had to go to a 2-day course in Washington, and you had to have a proctor present for your first 3 cases. So there's 7,000 interventional cardiologists in the US, and of course everyone wanted to do it. And I got invited to the first meeting because J&J knew I was using biliary stents and knew I had stent experience. And so literally within weeks, I got Shu Wong to come from Washington to proctor me through 3 cases. And we were doing coronary stents at North Shore in 1994. But the big, I think, advance was using the stents in acute MI setting, in a heart attack setting. And the reason that was a big advance was when we were putting stents in, the biggest fear was you're putting metal in the artery and you worried about a blood clot forming in the artery. And so now that we knew that a heart attack was a blood clot, putting a stent in a blood clot didn't sound like a good idea. And so actually the insert in the box for the coronary stents said it's contraindicated to use it in a heart attack environment. So what happened was one Friday, it was about early afternoon, a patient came in with an inferior wall MI to North Shore. We brought the patient up to the lab.
The lower portion of the heart, I'll translate.
And Larry Ong took the patient to the lab. He opened the artery, but he got a large dissection in the artery. And we were all really concerned about that. So, sorry, let me just get rid of this so it doesn't keep going.
While you do that, you do have a question, so maybe you can work this in. What's the difference between interventional cardiologist and a regular cardiologist?
Okay, I'll come to that.
Okay.
Me and him. I have no testicular fortitude. He has all of it.
So Larry Ong got this dissection. I was watching the procedure, and I said, Larry, did you read that article this week from Hong Kong? The 2 Wong brothers were using stents in acute MI, and they were getting good results. So he said, yes. I said, so put a stent in. So he put a stent in that patient. Of course, we were all really nervous about it, and the patient did great. So we started doing stents in acute MI. This was at least 4 years before the rest of the country started doing it. And we were absolutely convinced that the flow in the artery once you put the stent in was so much better than doing an angioplasty. So the question is, what is an interventional cardiologist? So my youngest son is a cardiology fellow in training right now. It's his 2nd year. So what does that mean? You finish medical school. You then do internship and residency. That's 3 more years of internal medicine training. And then you do 3 more years of training in cardiology to become a cardiologist. And then if you want to do stent procedures, you do an additional 1 or 2 years training in the cath lab to do interventional cardiology. And so my youngest son's a 2nd year cardiology fellow. He's thinking about interventional cardiology, which means he has to convince his wife to stay where they are for an additional time period.
So I'm a non-invasive cardiologist. I see patients in my office, I do diagnostic testing, and if I identify a patient where I believe they have a blockage or multiple blockages, to further evaluate that blockage, which is literally like, in your kitchen sink in the plumbing where you have a blockage of hair and kitchen crap blocking your artery. It's the same physiology.
Yes.
It's just the vessels are elastic. And so to identify this blockage, I send it to my colleagues who are interventional, and they have 2 years of additional training to put thin catheters into the arteries, wrist or groin, and direct them up to the openings, these small openings where the arteries that sit on the surface of the heart lie, and that's typically where these blockages occur, and they can do magical things.
Yeah, so just to expand on what Jean said, imagine your kitchen sink, you have a pipe draining whatever is in the kitchen sink, and junk is building up in the pipe, but there's still flow, so what you notice is the kitchen sink drains but slower. And then one day you're washing the dishes and it doesn't drain. And that's because that pipe under the kitchen sink is 100% blocked.
Correct.
And that's what a heart attack is. Now, also imagine you call the plumber and he doesn't know where to go into the pipe. He doesn't know where the blockage is, high up or low down. And so he injects a dye and takes an x-ray, and he can see where the blockage is in the pipe, and so he knows where to cut the pipe to clean up the blockage. And that's what we do when we do an angiogram. So just to expand on heart attack patients, 2 hours ago, a patient suddenly wasn't feeling well. He went to an urgent center. He had no history of heart disease, diabetes, high blood pressure.
Risk factors, for typical risk factors.
And he went to the urgent center. They did an EKG which showed he was having a heart attack. So they sent him to our emergency room. We brought him up to the lab. We did an angiogram. We found one artery was completely blocked. I opened it and put a stent in. And the magic of it is when the artery gets opened, immediately he's lying on the table in pain, like a light switch went off, the pain goes away, and he suddenly feels confident that he's going to survive and not die during this procedure. Now, if you remember, I said in the 70s they stayed 3 weeks in the hospital. Today is, what's today, Wednesday?
Mm-hmm.
He'll go home on Friday. So 2 days compared to 3 weeks. In addition, we really did as much as we know how to try and rescue his heart from suffering any damage. Now, it's unusual not to have any damage, but I would say doing what we did, we diminished the amount of damage by 50 to 70%.
So when you have that 100% blockage, no flow coming out of your sink, the heart muscle tissue behind that blockage is now deprived of nutrients and oxygen, and that leads to the death of those heart cells, and the dying cells convert into fibrous tissue, scar tissue, which no longer contracts. It doesn't allow the heart to beat in the same way, and that is probably the #1 cause of heart failure here in this country. As we treat these heart attack patients earlier and earlier and being identified, and the current recommendation is by the time they arrive in the emergency room and are identified to being in the midst of a heart attack, to getting into the hands of physicians, interventional cardiologists like Dr. Katz, ideally it's 90 minutes. I think it's extraordinary that here at Peconic, our average time from recognition in the emergency room to having that blockage opened is in the mid-50s minutes. So less than an hour.
So what does it mean that Peconic Bay has this capability? So 3 years ago, we did not. So it's very important to understand that the heart attack starts by when the artery becomes 100% blocked. And once that happens, the clock is ticking. And it's estimated that if you open the artery beyond 6 hours from the onset of that blockage, there is very little recuperation of the damaged heart muscle. Obviously, the sooner you open it, the more heart muscle you salvage. So Peconic Bay serves, 250,000 people? So what happened 3 years ago when we didn't have this? So someone would, like this man, would have gone to the urgent center, they would have said, you're having a heart attack, they would have sent him to our emergency room, they would have confirmed that he's having a heart attack, they would have got an ambulance and sent him to the closest cath lab at that time, which was Stony Brook. And that would have eaten up probably another hour and a half to 2 hours. And so that's 2 hours of more damage to the heart, as opposed to opening it up 2 hours earlier and saving heart muscle. So that is very important, and I can think of maybe 5 or 10 patients over the last 3 years and we've been doing maybe 40, 45 heart attack patients a year. There have been at least 5 to 8 dramatic cases that, in my opinion, if we didn't have the lab here, they would not have survived that extra 2 hours to get to another facility. So it has made a dramatic difference in the lives of some of the population out here.
Absolutely, and I think it is accepted that this is the gold standard of heart attack care. And so there is a big push for many local, we call them STEMI, it's the version of the heart attack that they're having, centers here on Long Island. And I think in the next year we'll see several new labs opening up so that we can keep care local. It is still Peconic Bay Medical Center because of the hospitals that are here in this region. We do, it's not only 250,000 people, but it's over 400 square miles of care that we serve, and so it's a really big region. And honestly, I can't imagine. I can't even remember going back to what it looked like, and I can only imagine in the hands of someone with a lot of guts and courage to take on new approaches where we're going to go in the next couple of years. And so while we have great heart attack care, and we have great heart attack aftercare, because we have a cardiac rehabilitation program here at the hospital as well to facilitate survivors to get back into their routine. And
so that's a good point, because everything is connected. So since the program has grown and expanded, our cardiac rehab program has grown and expanded, and we had to move them into new, larger facilities to accommodate all the patients that want to come to the cardiac rehab.
So just a reminder, the number one leading cause of death here in the United States remains cardiovascular disease. And so and as I look to younger populations, smoking more, vaping more, I unfortunately feel like there will be no shortage of future patients for us.
So there are other aspects of the program that are very exciting. We have a full-time electrophysiologist, Dr. Jadanath, who used to run the program at Manhasset for more than 20 years, very well trained in electrophysiology. And since January, he's been here. We opened the EP lab, I believe, in March or April. And literally the volume of procedures has tripled in that period of time. And this week, on Monday, he did a first for Peconic Bay, and that is he put a micro pacemaker in a patient. And what exactly is that? So normally a pacemaker is a box that generates electricity. It's put under the skin. It's connected to an electrical wire that runs through the vein to the heart and into the heart and has to seed into the heart so that the box pulses electric through that wire to the heart. The issue with that is you can get an infection where you put the pacemaker in, and invariably there has been several recalls of the electrical wire, which sometimes fracture. And so what the micro is, it's the size of a rifle bullet, and you go up the vein in your leg to the heart, and you literally screw it into the right ventricle. It has no leads, and it has an internal battery that can last up to 5 years. And when the battery runs out, you just put another one in. So we did our first one here on Monday.
So it's a extraordinary device, and there are other versions of pacemakers that are becoming available, some that can sit externally and can be removed if there is a rhythm disturbance that the patient recovers from. So all of these devices are available here at Peconic, and it's probably worth having Dr. Jadanath join us and let him, share some of the other procedures that he does where he can cure a patient from having an abnormal heart rhythm, which is, the holy grail in medicine, to be able to cure with a very elegant and straightforward procedure. Again, it's just fantastic for our community to have this expertise, right in your backyard and not having to. I think, I mentioned earlier that in addition to these two beautiful labs that are used for our rhythm therapies, the electrophysiology cases, and our plumbing procedures, the interventional cardiology procedures, we have this open space. And there are significant interventions in cardiology to treat structural abnormalities of the heart, leaky valves, tight valves. Aortic stenosis is the most common one, but leaky mitral valves, mitral regurgitation. These are procedures currently done at hospitals with open heart surgery to provide backup should something go amiss. But there are centers, particularly down in the South, where they're having such good outcomes. Not all that different than the evolution of what you were doing to what you're doing today.
Right. So in the 70s, in the 80s and 90s, you could only do angioplasty and stents in a hospital that had heart surgeons, because a certain percentage of these procedures could become catastrophic and the patient needs to be rushed to the operating room and have the surgeon try and save things by doing a bypass. It became apparent by the end of the 90s and early 2000s that the incidence of that happening where they needed emergency surgery was so small that it was literally 1 in 2,000 patients per year. And so the rest of the country and then New York State started approving doing angioplasty and stents in hospitals that did not have cardiac surgery, like Peconic Bay.
Like Peconic.
So I think what Jean was indicating was that right now these structural procedures, the TAVR valve for aortic valve, fixing the aortic valve, can only be done where you have heart surgeons. But I think what's become apparent now is that the likelihood of requiring emergency heart surgery for a TAVR is less than 1 in 200. And I think that the way things will evolve over the next 3 to 5 years is we will be able to do those TAVR procedures here without having heart surgery backup.
What can patients expect today in the hospital should they need to come for a heart procedure?
So I think that for every 100 procedures that we do, about 30 of the 100 will end up getting stents. Maybe 10 to 15 will require cardiac surgery or something like a TAVR, which is more complex, and will then need to be either transferred or sent as an outpatient to a hospital such as Southside Hospital, where there's a good heart surgery program. And the rest, it's really just diagnostics to see if we can figure out what's causing the patient's symptoms and whether it can be managed with medication.
And if the question is related to hospital life post-COVID, I think it's worth mentioning that for the past 6 days, Peconic Bay Medical Center has not had a patient with COVID-19 infection, and we haven't even had any that required hospitalization for suspected infection. And so for us in the hospital, I feel like we're back to business as usual. We are still vigilant in how we screen our patients. So every patient that comes for either a surgical procedure, we heard Dr. Krause talk about the joint replacement procedures, and all of our cardiac patients, before they arrive, are still being tested for COVID, because we do want to, consider whether now's the right time to do a procedure if there is a COVID infection. And then if we decide that it's absolutely necessary and we're going to proceed, we are committed to putting patients with a COVID infection and separating them from the rest of the hospital. And so we do need this information. Even though we're doing all of this, I don't think we've had any significant issues. We have a plan. We are prepared if for another surge. We've done an assessment on our response that started back in March. And we have a lot of good lessons learned, a lot of opportunities. But I think that we all, for the most part, feel that our response was excellent, and the fact that our mortality rate, I think we talked about this in one of our earlier programs, the number of patients that actually died from a COVID infection was 13%. It's incredibly low when we look at what's happening across the nation. And so we did well the first time around. We're prepared to do better the next time around. And for the moment, we are aware, we are vigilant, but we are operating as if healthcare is just moving forward. We're planning for the future, for future growth. Our surgical volume is right back where we left off at the beginning of March. We have caught up with all of our patients that needed their surgeries deferred. For those that are ready to come back, there are still patients that are saying, I'm going to wait a little bit longer, and we're ready for that. In the cardiac arena, these are acute events. Even when you develop unstable angina,
So there's
you can't, the heart doesn't wait.
so there's interesting information on COVID and heart attacks. So it has been commented upon in Italy and in Spain that they saw dramatic drops in patients with getting heart attacks during the COVID period. And a lot of doctors around the US kind of commented that they were noticing it. So there's a study that was published in JACC last month. They took 9 high volume angioplasty centers. North Shore was one of them. Not high volume angioplasty, but high volume acute MI centers, where they did 60 to 70 acute MIs a month. And North Shore was one of them. And they looked at the 3 or 4 months prior to COVID, how many acute MI calls did they get per week and for the month. And then they compared it to March and April. They didn't get to the May data yet. And they showed more than a 50% reduction in the number of times they had to come in and treat a heart attack patient in March and April. And it's an interesting phenomenon. I don't know the reason. One of the primary care docs said to me that they put the whole nation to bed rest. So maybe that's what the cause was. But it's an interesting phenomenon.
And yet, this morning, there was a publication that came out looking at COVID survivors, and 50% of survivors of COVID infection have some form of damage to their heart muscles. So they weren't presenting, and clearly there is some kind of phenomena that we need to understand.
So we have 2 patients that I can comment on. About 6 weeks ago, I saw a lady in the office. She's in her 70s, very active, worked out at the gym, walks daily for miles. And she came in April, early April, with COVID here, and was very sick. She was in the ICU. She wasn't intubated, but almost intubated.
Mm-hmm.
And during her illness, they did an echo, and her function of the heart went from 60, which is normal, down to 20.
Wow, which is markedly abnormal.
So very abnormal. And she got better, she went home, she now comes to see me in the office 3 weeks later. We repeat the echo and it was normal, 60. So she fully recovered. Another patient 3 weeks ago had COVID, was admitted to another hospital, and then a month after COVID got admitted here with heart failure, a man in his late 50s, early 60s. And we did an angiogram on him, and his pumping function was 15%.
Wow.
So we transferred him to North Shore Manhasset for consideration of a transplant. And he's on the transplant list. They worked with him for 2 weeks, and they have him on a continuous pump with strong medication. He's an outpatient now. I saw him in the office. And I repeated the echo this week, it was still 15. So he didn't recover.
Yeah, so there's, I think the bottom line with regard to COVID is there is still an evolution of information. We still don't have firm understanding of the pathogenesis of the problems that are associated with a COVID infection, whether it is the pneumonia or clearly affecting the heart. We know it affects the GI tract. We're learning that there's significant neurologic manifestations as well. So a lot of work being done, obviously, and for us here in New York State, it's really challenging, at least for me personally, to watch what's happening in the other states. You would think lessons would have been learned from watching our experience here. So, more to come. The nation needs to rally behind this. So I just, Producer Sam, are there any questions out there in the audience?
No, but any final thoughts, and then end with how do people reach you both? Because they always want to know how to get to you.
So just, to thank Dr. Katz for bringing me to this organization and the wonderful career I've had, but more importantly for bringing your expertise and your vision and your courage to the East End and allowing our patients to really benefit. We're just getting started here, I think, is the bottom line. So great work is happening, and there is more work to come, and it's all going to be exciting, and it will continue to transform care in this community. Dr. Katz
So
can be...
I can give you the office number. It's 631-727-7773.
And my office number here at the hospital is 631-548-6470. I want to thank you all for your time. It's been my absolute pleasure to have Dr. Stanley Katz, our chairman of cardiology here at Peconic Bay Medical Center, and the innovator of and transformative physician for heart attack care here in the tri-state area. Thank you all, and we'll see you soon.
Take care.